when we had the primary results of the study, we knew that we were going to go back and look at these biomarkers to ask the simple question, are there patients that we could identify from biomarker work that would do better with afatinib versus the standard of care methotrexate? In addition to that, we also looked at now a very important biomarker, and that is HPV status, and we used P16 to look at that. Again, with the hypothesis that there may be HPV subtypes, actually HPV negative patients, where data was telling us that they may actually do better with an EGFR inhibitor versus methotrexate or other agents. And so let's go through those sort of one at a time. First of all, let's talk about the P16, and strikingly, it looked like, in fact, it was the P16 negative patients that appeared to benefit from afatinib. In fact, we saw almost no responses in the P16 negative cohort treated with methotrexate. In other words, methotrexate was almost ineffective in that patient population, while we did see responses when treated with afatinib at a rate of about, I think it was exactly about 14%. Moreover, when we looked at EGFR amplification, again, we saw what we thought we'd see. The EGFR amplified patients, so these were at the gene level, so either amplification or increased gene copy number, those patients, again, appeared to benefit from afatinib versus methotrexate. And lastly, we took P10, which is a tumor suppressor along the PI3 kinase pathway, and HER3 as indicators of activation of the PI3 kinase pathway. And when we look at those markers, we saw what we expected to see. If P10 was high, and that is an intact pathway, an intact PI3 kinase pathway, those patients benefited from afatinib. And if HER3 was low, again indicating an intact PI3 kinase pathway, those patients benefited. So our hypothesis appeared to be real, or at least in terms of this preliminary testing, and it certainly gives us some ideas of where to take a drug like afatinib, if not afatinib itself, forward.